This is Chapter 15, Fetal Assessment During Labor. Electronic fetal monitoring is a useful tool for visualizing the fetal heart rate patterns on a monitor screen or printed tracing. It was first used in the 1970s. They used it anticipating that it would decrease cerebral palsy. However, the rate has not changed or declined. The primary mode of intrapartum assessment is fetal heart rate monitoring. Fetal heart rate generally ranges 120 to 160. You auscultate the fetal heart rate using a fetoscope or Doppler every 5 to 30 minutes during the first stage of labor and every 5 minutes during the second stage of labor. Also, assess fetal heart rates immediately after the rupture of membranes, particularly if the head is not engaged. This causes a risk for prolapsed cord. Frequently, continuous electronic monitors are used in the hospital setting. Continuous monitors are able to assess subtle changes in the fetal heart rate that may go unrecognized by auscultation. Toco transducers, which are placed on the abdominal wall to detect uterine activity, are used, such as seen in this picture. Ultrasound transducers, also placed on the abdomen, are used to detect fetal heart rates. Please look at the display on the picture. The intervals between the vertical red lines represent 1 minute. Fetal heart tracings are displayed in the upper pane. Uterine activity is displayed in the lower pane. A strip prints out both fetal heart rate and uterine activity as seen on both the screen above. External monitoring can be used in both antepartal and intrapartal periods. Does not require the membranes to be ruptured. The Toco transducer cannot assess the intensity of the contraction, which is the size of the heel that you see on the screen. Internal monitoring uses a spiral electrode applied to the presenting part of the to monitor fetal heart rates, and intrauterine catheters used to monitor contraction patterns. The internal uterine monitor is able to assess the uterine intensity, which is the size of the heel that you see on the strip. Internal monitoring can only be used in the intrapartal period because the membranes must be ruptured and the cervix dilated to 2 to 3 centimeters in order to insert the internal lead, and it's attached to the fetal head. Strip interpretation. Baseline. The baseline of the fetal heart rate is the average fetal heart rate over 10 minutes rounded to the nearest 5 beats per minute. On this strip, it is 145. Do you see the variability in this strip? This is normal. This is good. You want variability. Variability are those little bitty wave-like differences. The baseline of the fetal heart rate, and then you have some variability. The fetal heart rate is assessed in relation to the contraction. The contraction is a time of decrease in oxygenation. Increment is increasing in strength. Peak is the greatest strength, and decrement is the period of declining strength. Nadir is the lowest point. And you can see on here, onset to nadir is less than 30 seconds. That decrease, like that slope in the heel on the strip where those red lines are pointing down. See the strip in the picture, and you have variable decelerations. Okay, step 1, let's assess for contractions for frequency, duration, interval, and intensity. Frequency is the time from the beginning of one contraction to the beginning of the next contraction. Contractions closer than every 2 minutes may decrease oxygen to the baby. Duration is the time from the beginning of one contraction to the end of the same contraction. Contractions lasting more than 90 seconds may decrease oxygen to the baby. Interval is the time between contractions. There should be at least 60 seconds rest between contractions. Intensity, that's how strong the contractions are. If it is an external lead, the size of the peak does not matter. Must use palpation. Mild, it's easy to indent the uterus with fingertips. Moderate can indent more difficult, and strong can indent with a fingertip. Step 2, you must determine the fetal heart rate. Baseline fetal heart rate ranges from 120 to 160. The average fetal heart rate over 10 minutes rounded to the nearest 5 beats per minute. Here it is 145. Tachycardia. This is baseline more than 160 beats per minute for a duration of 10 minutes or longer. This represents first signs of hypoxia, maternal infection, maternal medication, or fetal anemia. Nursing intervention would be to lay the mom on her left side and add O2 at 10 liters mask and call the doctor. Bradycardia, fetal heart rate less than 110 beats per minute. This is a late sign of hypoxia, maternal medication, maternal hypotension. Again, nursing interventions, lay the mother on her left side, O2 at 10 liters per minute, and call the doctor. Determine variability. Normal fluctuations of the fetal heart rate from baseline between the sympathetic and parasympathetic nervous system, tells us about oxygen reserve. Absent or minimal variability indicates stress. Look at the peaks above or below the baseline waveform. Some variability is normal. If you have a flattened, dampened waveform, that is not good. You need some variability. 6 to 25 beats per minute variation around baseline. So let's look for periodic fetal heart rate changes, accelerations and decelerations. Accelerations of 15 beats per minute above the baseline with a duration of greater than 15 seconds but less than 2 per minute. Look for the fetal heart rate during the contractions and during interventions to see if the baby is tolerating this. Accelerations are usually reassuring that the baby is neurologically intact. Decelerations. This is a decrease in the fetal heart rate. There are 3 kinds. You have early decelerations, late decelerations, and variable decelerations. And you can start reading about this at the bottom of page 391, and it continues to page 395. So early decelerations, the nadir of the deceleration matches the peak of the contraction, and then you have recovery. Fetal heart rate returns to baseline by the end of the contraction. These are a good kind of deceleration, usually at the end of the very end when baby's head is getting compressed. Baby has an intact central nervous system in response to intracranial pressure. The reason the heart rate is dropping is a vagal response, and it's not from hypoxia. Mom is most likely complete and ready to deliver, so we are not going to do a vaginal exam. Sometimes early decelerations are called the mirror image of a contraction. Late decelerations, the onset or after contraction peak, fetal heart rate turns to baseline after the contraction. This represents a uteroplacental insufficiency, and there's a decrease in variability. The fetus is in distress, and immediate interventions need to take place. This can be a very detrimental thing for the mom and the baby. Oxygen is typically cut off to the fetus. We want to get mom on our left side, place oxygen, and call the MD. Let's discuss variable decelerations. They can occur at any point and usually more abrupt. Variable decelerations are usually in response to cord compression or a prolapsed cord. Maternal position with cord between the fetus and maternal pelvis. Short cord, there's a knot in the cord. Nursing interventions, you want to change the maternal position side to side, knee chest, discontinue oxytocin infusion. Administer O2 8 to 10 liters by non-rebreather mask. Notify the physician. Assist with vaginal or spectrum examination to assess the cord for prolapse, and assist with amnioinfusion if ordered. Fetal distress can result from hypoxia, indicated by non-reassuring fetal heart rate patterns. These patterns can include a progressive increase or decrease in the baseline fetal heart rate, a decrease in variability, late decels, variable decels. Another indication of fetal distress is the result of meconium being released from the fetal rectum in response to hypoxia, called meconium staining. This is a picture of a baby being born with meconium staining. Fetal response. Labor is a period of physiologic stress for fetus. Frequent monitoring of the fetal status is part of nursing care during labor. Fetal oxygen supply must be maintained during labor to prevent fetal compromise. Remember, the goal is to always oxygenate the placenta during the pregnancy and oxygenate the fetus. Fetal oxygen supply can decrease due to reduction of blood flow through the maternal vessels as a result of hypertension and hypotension, reduction of oxygen content in maternal blood as a result of hemorrhage or severe anemia, alterations in fetal circulation with compression of the umbilical cord, and a reduction in blood flow to the intravillous space in the placenta. These can all cause a decrease in fetal oxygen supply. When monitoring the normal uterine activity during pregnancy and labor, you're going to monitor frequency of contractions, duration of contractions, strength of contractions, resting tone, and relaxation time. Goals of intrapartum fetal heart rate monitoring are to identify non-reassuring patterns indicative of fetal compromise. Non-reassuring fetal heart rate patterns are associated with fetal hypoxemia. If uncorrected, they can progress to fetal hypoxia. Baseline fetal heart rate is 120 to 160. Preserved beat to beat and long-term variability. Accelerations last for 15 or more seconds above baseline and peak to 15 or more beats per minute. A typical adequate labor pattern may be described as at least 200 Montevideo units, resulting in progressive cervical changes. A Montevideo unit are derived from subtracting the resting tone from the peak intensity of each contraction in a 10-minute period and adding those values together. This picture depicts calculating Montevideo units. This is a picture depicting units to help monitor fetal heart rates. Baseline fetal heart rate is averaged during 10-minute segments, excluding periodic or episodic changes, periods of marked variability, segments of the baseline that differ by more than 25 beats per minute. There must be at least 2 minutes of interpretable baseline data in a 10-minute segment of tracing to determine the baseline. Page 388 in your textbook. Variability of the fetal heart rate can be described as irregular waves of fluctuations in the baseline fetal heart rate of 2 cycles per minute or greater. It is characteristic of the baseline fetal heart rate and does not include accelerations or decelerations of the fetal heart rate. Variability is quantified in beats per minute and is measured from the peak to the trough of a single cycle. 4 possible categories of variability have been identified: absent, minimal, moderate, and marked. Absent or minimal variability is classified as either abnormal or indeterminate. It can be a result from fetal hypoxemia and metabolic acidemia. Other possible causes are congenital anomalies and pre-existing neurologic injury. Central nervous system depressant medications, analgesics, and anesthesia may also cause this. See this information in your book, page 390. Moderate variability is considered normal fetal acid-base balance. This is in your book, page 390. Chorioamnionitis is associated with severe fetal anemia. It's an inflammation of the fetal membrane, fetal sepsis, and administration of analgesics. This is also in your book on page 390. Evaluation of the electronic fetal monitoring equipment. We want to evaluate the pattern recognition, must evaluate whether the pattern is normal or abnormal, anticipate time interval until birth, and determine if intervention is needed. So when you're monitoring fetal heart rate tracings, there are 3 categories. Category 1 is normal, Category 2 is indeterminate, and Category 3 is abnormal. And there are fetal monitoring standards of care that nurses who monitor these fetal heart rate tracings, they're trained and they have to abide by those standards of care. Additional methods of assessment and intervention: fetal heart rate response to stimulation, fetal scalp stimulation, vibroacoustic stimulation, umbilical cord acid base determination, fetal scalp blood sampling, amnio infusion, and tocolytic therapy. You can find information on each one of these starting on page 396 through page 398. Patient and family teaching. You want to teach maternal positioning for comfort, pain management techniques such as breathing, avoid supine position, maintain side-lying position or semi-Fowlers with a side lateral tilt to the uterus. The goal, remember, is to always improve fetal oxygenation. Documentation. What, when, how, who. Computerized charting. Not charted, not done. Clear and complete documentation. Fetal heart rate. Assessment must be documented. Institutional policies for strip notation. Most institutions require a printed strip posted and it's scanned into the computerized EMR system. 5 essential components of the fetal heart rate tracing. Baseline rate, baseline variability, accelerations, decelerations, changes or trends over time. Key points. Fetal well-being during labor is gauged by the response of the fetal heart rate to uterine contractions. The monitoring of the fetal well-being includes fetal heart rate and uterine assessment and assessment of the maternal vital signs. Patient and family teaching about fetal heart rate monitoring. Explain the purpose of monitoring, explain the procedure, provide rationale for maternal position. Explain fetal status can be assessed continuously even during contractions. Explain that the lower tracing is the uterine contractions and the upper tracing is the fetal heart rate. See page 399, box 15-9 for all education. Read all family and patient teaching. Thank you. This is the end of chapter 15.